Hi, my name is Kayla Carter, and I am a master's athletic training student here at Merrimack College, and I'm here to share my peroneal tendonitis case study that I experienced last semester during my clinical rotation at the college setting. So just some background on my patient. He's a male and he was a senior in college, so he's around 21 years old. He was on the track team. He threw both shot put and discus. And something else that we had to keep in mind during our evaluation of this patient was that he has a previous history of surgery to his ankle due to a tibial spiral fracture, and then he also sustained a grade 3 sprain of his ATFL and AITFL. And then so now he currently has a screw and plate in his ankle for which he had received surgery to get in his sophomore year of high school. So, and then going into the presentation of this patient, he came in limping to the athletic training room for us to do an evaluation on him. He said he had a feeling of instability during practice, so he couldn't really put any weight on it, so he wasn't able to finish his practice, and that's when he had come in for us to look at it. He said he had a sharp pain in his right lateral ankle, which he had also been experiencing pain in the area since practice had started at the beginning of the school year. So this was kind of going back. This was last semester, was the fall. So that was when sports had kind of started back up again, especially following just the pandemic and everything closing down due to COVID. So he hadn't really been able to exercise as much as he would usually do during the summer leading up to practices at the beginning of the school year. So he had come back to school, and all of a sudden he had started this rigorous practice and exercise schedule that he was not used to, especially following that long period of rest during the summer, as well as that shortened spring semester that they had spring semester. So he wasn't really able to do much at all leading up to this semester. And then also in the area we observed an obvious pocket of swelling, which was visible posterior to the lateral malleolus. In addition, we also saw a slight navicular drop on his right foot, meaning that we saw that collapse of his heel inwards. Or not his heel, a slight collapse of his arch inwards. And then when we did a further observation, he had a slight aching pain during passive inversion. So that was just with me moving his foot. And then he also had pain during active range of motion and dorsiflexion, plantar flexion. So dorsiflexion, moving his foot upwards, and then plantar flexion, moving his foot downwards, as well as inversion and eversion. And then just further testing that we did with him, we did a manual muscle testing of the anterior tibialis, for which he had a 5 out of 5, meaning that he had full strength and there was no pain. So he was able to fully resist any weight that we had put down on his foot during that manual muscle testing. And then the next muscle that we tested of his ankle was the posterior tibialis. So we did see a slight navicular drop, which is usually due to a weak posterior tibialis. So during this manual muscle test, we did see that there was just slight weakness in that posterior tib, as he wasn't able to score a full 5 out of 5 on that test. And then the next muscle that we tested were the peroneals. And the main action of the peroneals is plantar flexion in addition to eversion of his foot. So during this manual muscle test, he had got a 3 out of 5, meaning that there was not full strength against that resistance that we put down on his foot during that action. And then in addition to that, there was also pain that was accompanying that testing of that muscle. And then the two other muscles that we tested were the gastrocnemius and the soleus, both of which are in the calf of his lower leg. So the gastroc, he got a 5 out of 5 on that test, and the soleus, we saw he had some slight weakness with that soleus as well as some tightness. So he got a 4 out of 5 for that manual muscle test. And then just other testing that we did. So some special tests that we did. The first one was the Thompson Test, which is just a slight squeeze of the calf muscle to look at the integrity of his Achilles tendon. For that test, he got a negative result, meaning there was no injury to that Achilles tendon. And then other tests that we did to test the ligaments of his ankle were their anterior drawer, talar tilt, and then Kliger's. So for anterior drawer and talar tilt, they were both negative tests. And then for Kliger's, for Kliger's test, you do maximal dorsiflexion, so you bring that foot all the way up, in addition to maximal eversion of the foot. So for those, there was negative for laxity of the ligaments, but he did get a positive for pain during eversion, which we had already seen and should expect due to his manual muscle testing for his peroneals, which we saw was also pain. He had pain with. And then another test that we did was the bump and squeeze, and that is to rule out fracture. And for both of those, he got negatives. So really what we were targeting during this test was to really rule out any ankle sprain and then fracture, and then also check to make sure there was still integrity of the screw and plate in his ankle, especially looking back at his background as he had that surgery. And thankfully, there was no damage to either or any of those structures. So the diagnosis that we got upon was that he has peroneal tendonitis, which is probably secondary to or due to the weak posterior tibialis and the tight and weak soleus that we observed during manual muscle testing. So now just to give some background on what peroneal tendonitis is, so it is an inflammation of the peroneus longus and or the peroneus brevis tendon or tendon sheath. So if you just look to the right here at this big diagram of the ankle, you can see just highlighted in red is where the peroneal tendons run. And then where we saw that pocket of swelling is just, if you look at the lateral malleolus, which is that bony prominence there, the pocket of swelling was just behind that swelling, so a little bit proximal and posterior. And then, so just your typical mechanism of injury for peroneal tendinopathy is prolonged or repetitive activity, commonly seen following long rest period or a significant increase in activity. So both of these we observed in our patient during our history that we took with him. He had that long break over summer where he didn't do much activity, and then the school year started, and then he just had lots of practice commitments and then lots of exercise commitments. So he just had a lot to do, and then he just did a lot of loading on that ankle. So his pain had started out slightly at the beginning and then just gradually picked up as that large activity or significant increase in activity was sustained over a long period of time. And then just some risk factors that are typically seen or observed in people or patients that are likely to get a peroneal tendonitis. So one of the first risk factors is cavovarus foot positioning, which means a high arch in your foot. Actually, with our patient in this case study, we observed the opposite, as he had a slight navicular drop. So that arch was actually a little bit collapsed instead of it being abnormally high. And then just some other risk factors that we want to keep an eye out for our various hindfoot alignment, lateral ankle instability, some of which we did see in this patient, as he said he reported a feeling of instability, and he was also has a previous history of that tibial spiral fracture and grade 3 sprain of the ankle, so he's bound to have a little bit of instability in that ankle if he didn't do proper rehab from that surgery. And then just the last risk factor that we want to look out for, low-lying peroneus brevis muscle belly. And then just moving on to our key differential diagnoses, all of which that we had ruled out during our evaluation history and testing. So lateral ankle sprain, lateral ankle instability, peroneal tendon tear, and then just fracture to the fibula, cuboid, or fifth metatarsal. And then just moving on to prognosis. Peroneal tendinopathy is a chronic injury, meaning that it happens over a long period of time. There's not really any just like sudden injury, or like he was hit or he fell and then this injury happened. It's just something that comes about as a process. So due to that, it can take a long period of time to resolve. So 2 to 3 months is what I saw in my research, and also what I observed with this patient. And then just the effects of treatment may not show instantly. Thankfully for this patient in this case study, the acute treatment that we did with him, he found like results right away. Like he felt better the next day. So, but not everyone may observe this in their patients. And then furthermore, with prognosis, if the root cause is not targeted, the injury will continue to return. So looking at this case study with this patient, if we don't target his weak peroneal or posterior tibialis and then his tight and weak soleus, the peroneal tendinopathy will continue to affect this patient. So that's just what we really want to target in our treatment. So just moving on into treatment. So the acute treatment that we did after our evaluation of this patient, we iced him, we put him in a game ready, which is just a boot that provides both compression and like an ice massage to the patient. And then while he was in that game ready boot, we elevated him, and then following that, we sent him home with an ACE wrap to provide further compression to that swollen site on his ankle, as well as a crutch to aid with walking, as he really couldn't put any weight on his ankle and was limping when he came into the athletic training room when we first saw him. And then just moving on to rehab, we want to look at just these 3 main goals, especially with this patient. He had a tight and weak soleus, so we want to really target some stretching for that tight soleus. So what we did for that, as you can see in the middle, we had him do slant board, and to target that soleus, we had him do a bent leg on the slant board to target the soleus. And then while he was on there, we also had him do straight leg, because we might as well just stretch the gastroc while we're also stretching the soleus. And then the next thing that we want to look at as a goal for exercise is strengthening. So he has a weak posterior tibialis and then a weak soleus. So some of the 2 exercises that we did for him was 4-way ankle. So we really had him do every single motion of the ankle, so dorsiflexion, plantar flexion, inversion, and eversion. And then just the main action that we really wanted to target for that was the action of the posterior tib, which is dorsiflexion and eversion. So we really put big emphasis on that during those 4-way ankle exercises. And then the exercises that we did to target the weak soleus was calf raises with a bent leg, and then eccentric loading of the soleus with a bent leg that you can kind of observe on this really tiny picture on the bottom left. But we had him on like a box, and then his heels were hanging off the edge, so then he would slowly drop his heel on the back of that box, so that would really stretch as well as strengthen the soleus muscle. And then the last goal of our rehab exercises is proprioception imbalance. So what we had him do was we started out doing a double leg stance on an RX pad, which is just a foam pad for him to balance on. And then as he progressively got better, we moved him to just a single leg stance on that board where he would balance, or on that foam pad where he would balance for 30 seconds. And then we also moved for the calf raises from a double leg stance and then to that single leg stance as he got progressively better and had more strength in his lower leg muscles. So we had to make the exercises harder for him. But yeah, so that was my case study for peroneal tendonitis. So when I first looked at it, I didn't find much information out there concerning the presentation and treatment of peroneal tendonitis. So I wanted to use this case report as a way to maybe guide another healthcare practitioner who may come upon a peroneal or a patient suffering from peroneal tendonitis, and may find that this case support can act as a guide for them to find maybe appropriate treatment or rehab for their patient. So thank you for listening.